Hello and welcome to the ESSO training in surgical oncology. Myself and Professor Pomplio Piso are the chairs for the evening. So let me introduce Professor Piso. He's one of the leading surgical oncologists in Germany. He was one of the founders of the Association for Surgical Oncology, which he chaired for 6 years. In this time, he had enabled the introduction of structured specialization within a curriculum of surgical oncology in Germany, together with ESSO and UEMS. He was also part of the board of directors for the European Society of Surgical Oncology for 4 years, emphasizing the importance of oncopolicy and the presence of surgical oncology in the European Beating Cancer Plan. He also supports the surgical community beyond oncology and was the president of the German Society for General and Visceral Surgery. Tonight, we will look at education and training in surgical oncology and how it is important, and see the increasing because we see an increasing incidence of cancer worldwide. With the increasing age of the population, the cancer treatment pathways need to consider comorbidities and the quality of life of patients. For a robust workforce to exist, we need good training programs in place that provide fit-for-purpose workforce. We need the correct tools and resources to enable good quality of care for patients wherever they are in the world, to have an equal health care for all our patients. This webinar will look at training in surgical oncology across different countries and if there is uniformity across these. One of the things I should do is to introduce you to ESSO and what ESSO stands for. So I encourage you to, so there's some housekeeping. So first of all, I would encourage you to use the Q&A function to actually ask any questions that you may have. The webinar is being recorded and the recording will be shared with you after the webinar. Feel free to submit as many questions as you like through the Q&A function. I would recommend that you ask the questions as we go along. And obviously, there's a few social media links there that you can follow. So we know, so what does ESSO actually do? It actually has more than 4,000 members worldwide. It has an annual congress that happens every year, and this year it will be in October 2025. The courses are advertised on the website, so I do encourage you to go to the website. Educational grants to help advance careers, educational research are available through ESSO, and I do encourage you to go to the website, definitely to look at them. So this is a slide giving further information of what ESSO does, and ultimately it is about curing cancer together. If you're interested in getting involved in these activities, then the next slide is what you'll be interested in, which is how to become a member. I just draw your attention to the QR code, but obviously on the website it tells you how to become a member. And I do encourage you to look at what ESSO does and see how you can get involved in the debate, which is very important. Just bear with me a second. So our first talk for the evening on surgical is called On Surgical Oncology in the USA, and it's given by Dr. Chandrakant Ayer, who is the CEO of the Global Forum for Cancer Surgery. Dr. Ayer holds the title of the Gerald R. and Carolyn J. Varner Professor of Surgical Oncology and Global Health. He is the Associate Dean for Graduate Medical Education for the College of Medicine and the Vice Chair for Education in the Department of Surgery. He also serves as the Surgical Director for the Davis Global Center, the Simulation Center at the University of Nebraska Medical Center. So I stop sharing there and I hand over to him.
Do you see my screen? Yes?
Yes, we do.
Oh, brilliant. And looks like you can hear me as well. So first and foremost, I do want to thank Dr. Ilanko and Dr. Piso for this wonderful opportunity. It is a privilege and honor to be here. As we were talking earlier, it's always nice to have this collaborative activities, and I look forward to the talks of the other speakers, and it's nice to see Dr. Somashekar here, another leader from India that's pioneering many things there. So I was asked to talk about training in surgical oncology, the perspective from America. And as someone that's been involved in education for a long time, you may notice some biases, but I will try my best to stay unbiased. So coming to disclosures, I have none. And the objectives of my talk today will be sort of in 4 parts. The first one is to define who is a surgical oncologist or what is surgical oncology, and then the training pathway in the US, and what is the current status of that training pathway in America. And just one slide on what some of the issues and challenges are. Now, while I will be talking predominantly about what happens on this side of the pond, since I do a lot of global work, you might find some of those global thoughts might permeate throughout this talk of mine. So the first thing is, who is a surgical oncologist? Now, this is a definition from National Cancer Institute. It kind of says a surgeon who has special training in performing biopsies and other surgical procedures in cancer patients. So it could be anyone, not just fellowship trained people. It could be a general surgeon. It could be a GI surgeon. So if you look at it, this is something different people have different definitions for this, and not just in America, but as you travel the world and across, when you say surgical oncologist, does it mean a fellowship trained person like me? Or does it mean a general surgeon that knows how to do cancer surgery well? And the reason I say that is, as many of you know, not just in the US, in most of the world, 80% or more of cancer surgery is done by non-fellowship trained surgeons. Now, who they are, what the training pathway is, can be very variable. But at least in the US, 80% or more of the cancer surgery is done by non-fellowship trained surgeons. That means surgeons not like me. That means surgeons that did not do a surgical oncology fellowship. Now, when you talk about fellowship, it's not just one type of fellowship, because there's a fellowship in surgical oncology, and in some parts of the world, there's surgical gastroenterology, there's gastroenterological surgery, then there's breast surgery fellowship, endocrine surgery fellowship. So the number of fellowships are so numerous to define in one talk, and that brings us to the practice part. When we talk about training in surgical oncology, whatever the training pathway or pipeline is, that will produce that surgeon that will be doing that type of surgery. So if you come out of a surgical oncology fellowship like the one I did here for 2 years, where we get exposure to everything, GI, some part thoracic, some part GYN, I could be doing any one of those when I come out. Or if you do a HBB-based fellowship, you're only going to be doing HBB oncology in addition to some benign stuff as well. So I think it's something me and Dr. Elanco were talking before we started. On the global stage, this is something that still needs to be defined. And I know in Europe and ESSO, you're putting in a lot of effort in trying to define the specialty and who should be doing cancer surgery and so on. But I wanted to start my talk with this because this will lay the background for the rest of the talk. So now coming to the US, how does it work here? Now, each country is different, each region is different, but in this, I will be purely talking about how it works in the United States of America. So every year, about 4 million plus graduate from high school, 12th class or 12th grade. And of them, some go into jobs directly, some go into 2-year college degrees, some go to community college degrees to do vocational training, but many go into 4-year undergrad degree. And that 4-year undergrad degree is a prerequisite to get into med school. Unlike, let's say, when I went to med school in India, I went right after 12th class. But in the US, if you want to get into med school to eventually become a surgical oncologist, you have to do this 4-year degree. And of the numerous colleges in the US at any given time, there are about 11 million students, of whom roughly about 2 to 2.1 million graduate every year. And once you graduate from that, then you can apply to get into med school. Going back 100 years ago, there were so many med schools that quantity compromised the quality. And then we had the Flexner report that came out in 1910 that maintained some standards, and that reduced the number of college medical schools from, I think, 100 plus to about 40 or 50. And it took a greater part of the century for those number of med schools to come back up to more than 100. So there are about 130 medical schools or so, about 52,000 applicants, and about 23,000 matriculate into med school every year. So of these, if I choose during my 4 years of med school that I want to go and be a surgical oncologist, I need to do a surgical residency first. So as of now, there are 364 programs. Each program is 5 years long, and there are roughly about 9,700 total residents spread out over 5 years. It's roughly about 15 to 1,700 residents in each of the 5 years. Now, surgical residency in the US is 5 years, but most of us that are interested in surgical oncology during that 5 years, usually between second and third year, but some go between third and fourth year, like I did, we take 2 to 3 dedicated years out of clinical work where we just do nothing but research. And is it absolutely essential to do that? I wouldn't say absolute, but it's very common and it's understood that if you're going to go into surgical oncology, you're going to take those 2 years off and go into some lab and do some research in oncology-based stuff or related stuff. So med school is 4 years, then residency is 5 years, but for most surgical oncologists, it's 5 plus 2. So if you take my division of surgical oncology, where we have 11 surgical oncologists, the ones that did the Surgeon Fellowship, pretty much everyone took 2 years off. So once you finish your surgical residency, then you apply for a surgical oncology fellowship. Now, I must caution everyone again, when I say surgical oncology fellowship, this is understood to be the 2-year complex general surgical oncology fellowship. This is very different from a HPV fellowship, head and neck surgery fellowship, or a breast fellowship, or thoracic oncology fellowship, or any of those. So it's the 2-year surgical oncology fellowship. As of now, we have 34 programs that can accommodate 133 fellows. So that is the training pathway. So right from K-12, after you finish 12th grade, it's 4 plus 4, 8, plus 7 is 15, plus 2. It's 17 years of training after you finish high school. So what is the current status? So this just gives you an idea. The Surgical Oncology Fellowship in the US has been around for a long time, but it was a fellowship that was accredited by the Society of Surgical Oncology, not ACGME. ACGME is Accreditation Council for Graduate Medical Education that accredits all residencies and fellowships in the country. We've been working on getting accredited through ACGME, which happened about 10 years ago, give and take, and the trends in the last 5 years, with a minimal increase, let's say the number of programs increased by 17%, the number of fellowships, number of fellow positions increased by about 15%. So in the next, I think I have 2 or 3 more minutes left, just briefly. So what are some of the issues and challenges? Sejong is one of the most competitive fellowship programs to get into in the US, along with maybe peds surgery or something. And it was competitive when I was trying to get in. It still remains competitive. But for those that don't go in and they kind of wonder the workload, and this is not unique to America when I talk to my friends across the globe. Unlike my day when we went in, when we never thought about anything else, these days, appropriately, work-life balance is very important. And I think it should be. So for some people, although they may love the specialty, they say the type of patients is very draining and so on. So it can be a little hard. And then what I don't think there's an answer here, nor will we get an answer in this seminar or in the near future. Is it going to be a general surgical oncologist that does everything, or organ-based like myself that does HPV? And that's yet to be decided, not just in the US, but in other parts of the world, but definitely in the US. There are some that do broad-based, some just say, I'm only going to do colorectal and nothing else. Then there are other training pathways, as I mentioned. You can do oncology by doing a colorectal fellowship. The only difference is you're going to be doing some benign stuff as well. Or you can do a HPV fellowship. That is a 1-year fellowship. You're going to be doing benign stuff there as well, or a breast fellowship. And then you have other specialties that are sort of competing for the same type of work that you do. Transplant does HPV, thoracic does esophageal surgery. And then you have interventional radiology that's kind of getting into this interventional oncology that's making more and more of surgical procedures less invasive. And then not to forget, you have medical oncology and radiation oncology. They're seeing significant advances, which are very beneficial for what we do as a surgeon. But at the same time, there are areas of overlap. So for example, you give neoadjuvant therapy in esophageal cancer or rectal cancer. What do you do with those 15 to 25% of patients who have a complete response? So that is in a nutshell about the training pathway in the US. I'm happy to take any questions, but it's my pleasure and honor to be invited. And I want to thank Dr. Elanco and Dr. Piso for this wonderful opportunity. Thank you.
Thank you very much. We already had some questions. Your presentation has a very great resonance among the people that have joined the webinar. Thanks again. I will discuss it at the end. And we will move now to the next talk, which is Professor Somashekar from India. He's a highly regarded surgical oncologist, at present chairman at ESSO Healthcare of the Medical Advisory Board, and also global director of the Institute of Oncology from ESSO International. But he's still spending a lot of time in the OR, and he was trained in several universities in many countries across the globe. And he's interested in surgical oncology, but also in gynecological oncology and thoracic oncology. And I saw that he has a special focus on new technologies which are used in cancer treatment, such as robotic surgery. And he has done quite a lot of those. We just discussed this previous webinar, almost 3,000 procedures, which is really a lot in complex robotic oncosurgeries. And I know him from the executive committee of the Peritoneal Surface Oncology Group International, because he's very active, done more than 1,000 cytoreductive surgeries with regional chemotherapy. So I'm very glad that he joined this webinar, and he will present us some aspects from Asia, which you will see are somewhat different to the North American ones, and for certain different to the European ones. Thank you very much for joining us. Your stage.
Thank you, Professor Piso. That's lovely, and it's my honor and pleasure to be here among all my colleagues. Thank you for welcoming me. In the next 12 to 13 minutes, I'm just going to cover the surgical oncology training in India. What is the current status, challenges, and the perspective, and how India evolved and structured and still evolving, and how is its global relevance. I bring warm regards from my institution. I have no disclosure pertaining to this talk nor any COI. So in India, what does it take to become a surgical oncologist? It's a very different issue compared to other people in the world, actually. Somebody who aspires to be a student, you need to first finish your 12th grade. And then once they do this, then there is a very competitive world. Remember, India is a 1.4 billion population, extremely talented, very hardworking students. And we always say that 99% is just not adequate to get into med school. Million students give this exams, which is a undergraduate national NEET exam conducted by Ministry of Health and the National Medical Council. Then we need to get into med school, which is like cream and the cream of the class, which is a 5.5-year training program, including 1 year mandatory, training program in the hospitals. Then you need to do a basic graduation, which is a master's in general surgery, which again goes through a national entrance exam, which is even highly competitive, which is for 3 years. If you're lucky, you can now enter the surgical oncology program, which we call a super specialty MCH or Diplomate in National Board Surgical Oncology program, which is 3 years. Then are we ready for training and starting our program and surgical practice? Maybe, may not be. Then there are fellowships for 1 and 2 year in robotic or HBB, thoracic, others. So this is what it takes in Asia for us to do. Now, I will just show you how the surgical oncology is the most sought after #1 training program in India. On left side, I've listed all the places where you can get it trained: north, south, east, west. As you know, India can accommodate the entire Europe and a lot of Americas. It's a very big, vast country. But among all the students, once they finish their master's in general surgery program, when they apply for a national common single entrance competitive exam, 44% of them usually prefer a surgical onco, followed by a GI, then the urology, then the plastic surgery, and then subsequently the pediatric surgery, which means surgical onco training is the most sought after, highly competitive field. That means it's that much tough for us to get in. So how does this actually emerged? In India, the proper surgical oncology started in the year 1984. Till then, all the cancers were done by a general surgeons. So it initially started in the southern state of Chennai, the Adair Cancer Hospital. Immediately in the year 1985, it started in the GCRI, the Gujarat, which was started by Professor Dr. D.D. Patel. So 1984, 1985 is when the proper term called surgical oncology, 3-year Masters in Surgery training program started. Then it started in many other centers. For quite some time, like when I did my surgical oncology training, there were only 6 seats. Out of million students who appear, if you're not in top 6 rank, you don't get surgical oncology. You're 7, 8, you don't get it. So 6 out of millions. Then the government found that there is a huge disproportionate area between the number of cancer patients and specialists doing. So the Ministry of Health, through a separate parliamentary act, brought about a national board called as a Diplomate of National Board. And it is a national board examination which was launched. And then it started in 2010, a Diplomate in Surgical Oncology program other than the MCH. Then 2020, the fellowship program in advanced organ specific started. Now you can see, unlike the Western world, what you have in India, it is not subspecialty based, like not colorectal, gyne-onco, breast, thoracic, upper GI, hepatobiliary. In India, the MCH program in surgical oncology actually is disease based. Means what? Cancer surgeries, all of them, except the neurosurgery, the brain per se, is all done by the MCH surgical onco. So it would be colorectal, thoracic, breast, head and neck, thyroid, lung, soft tissue sarcoma, bone tumors, everything. So it is not an organ based in India when it started, but a disease based. So we don't do benign work, only cancer. So suppose you have a colorectal training program, you do a benign and malignancy. Suppose you are in thoracic, you do benign, malignancy. Here it is at GI, you would do both. No. Surgical oncology is a disease based in India for quite some time. So there are 3 ways system people can enter: a fellowship program which started recently, or a National Medical Council MCH program, or a Diplomate of National Board. I have put here how in Asia and in India you have. The Ministry of Health has an act called National Medical Commission, which was a previous medical council. And now this governs the surgical onco training, which by law are recognized. So you get registered and you are certified and you can do. There's a second way. If you're not attached to a medical college or a university, you can get into the Ministry of Health National Medical Examination Board or the diplomate. It is equivalent to the MCH program. Then now recently, the society, the Indian Society Association of Surgical Onco, Breast, and then also university programs, which are not recognized by national body or by law or the registry of the medical council, but you can do that. They are not so popular because they're just 1.5 to 2 year training program, not equivalent to these two programs to get into universities, your promotion, your professorships. So in India, this is how it has started now. So an MCH Surgical Onco is the only surgical onco training program. It is a 3-year program. You need to do your master's. It is both in private as well as government institution. There is an entry exam and there is a national exit exam. So it's very well structured. The diplomate of surgical onco is more in outside the university program, more rigorous exams. The passing percent is like 30-35%. Out of 170 don't make it, and then again they have to reappear, and they too have exit exams. So these are the 4 programs under which in India it happens. But mind you, all of them are disease based. Your surgical onco means you do from top to bottom, and now over last couple of years organ based program has started. So if you look back what it takes, about 5.5 years, 3 years, another 5 years, then 2 years, and then fellowship, what it takes. It's like a decade of training in onco you need to do to come back. I have now compared vis-a-vis India, China, the USA, and then the Netherlands, how it is. Based on the Human Development Index, like middle, high, and high, the physician ratio in India is in oncology 1 per 1,400. So it is a large gap. And the training period roughly takes 13 to 14 years, unlike 17, 15, and 15 in other place. And as of today, only an output of 100 to 150 for a huge country with a huge disparity is available. And there is a beautiful paper which is published by my colleague in Indian Journal of Surgical Onco. You can see a snapshot how there is a huge difference for us to go through. So how is the training program? Predominantly clinical and surgical, high volume. For quite some time, publication, academics, research took a beat because of a huge population and high workload. Now, since last 7-10 years, a lot of academics and then the publication research is taking a major shift. So during the surgical onco in India, you get co-rotated in GI, head and neck, gynec, breast, uro. So you learn everything. Pretty much you do everything. 99% of surgical onco do all the program from top to bottom. However, last 5-6 years, now specialized program into each has been started. So now most of the programs in India now are getting aligned with the ESSO, SSO, collaboration with various SAARC, Gulf and Asian regions, and then they're getting accreditation beyond India. So the training goals in India predominantly is not, a specific to a GI or onco, not a subspecialty based, but it is a knowledge of the entire onco, the surgical, medical, radiation, and research, so that quality of life and improving survival in cancer patient in a huge country is there. But now subject specific surgical onco has started, like MCH in gynae onco, MCH in head and neck, MCH in breast. So this is a beautiful paper. In the last 1 minute, I'll conclude. My colleague, who is an executive editor along with me in Indian Journal of Surgical Onco, wrote, does that mean the training in India so far, is it like being of jack of all trades because we do top to bottom, or is it time to move to a Western world where you do a specific cancer center? So we are overburdened with work like radical surgeries, palliative, risk reduction surgery, everything, community oncology, research. So, you wear multiple hats and you do extensive work. Like our outpatients are like 100 patients every day, and you do about 1,000 surgeries a month. And in that logbook, dissertation, academics normally suffer till now. But now there is a huge thirst to research and doing it. If you can see, earlier we had 1:1 mentee. But now the government of India changed the rules to accommodate more trainer. Now each professor like me can take 3 per year. So we would anytime have 9 surgical onco super specialty training per teacher. So it would little bit dilute our time and space we allot for research. So now slowly from a unit-based training program, we are moving into a disease management group, which was not there before. And now in India is trying to move this. So you can see I just put a snapshot of now subspecialty of surgical onco, which are available in national board, GI, thoracic, breast. These all started just recently in advanced fellowship program, post 3 years of surgical onco training. And now organ-specific program like head and neck, gynae onco, and breast are just started a couple of years back. So the key issues, quantity is huge for us, so quality suffered till now because of the high volume country we have to do. Now we are moving to a structured training curriculum and a long duration training. But these are all the challenges in a vast country we have, bringing uniformity, equal exposure to all the candidates, north, south, east, west, central, skill assessment, and patient training and surgical training. Till now, research output was not a thirst, but now we can see last 5-7 years, publication, research activity, and knowledge has taken a very important step. And I'm very happy that this shift has happened. So if you look back, a country like ours, we had to tailor make. 1.4 billion population, millions of cancer patients, overburdened outpatients, inpatient. Organ specific was very tough when we have 1,400 to 1 surgical onco ratio. So the learning, creativity, and thinking has changed, but still we are able to cater large amount, but still 70% of cancers are done by general surgeon in India because of the lack of structural training. But now we have about 250 per year seats, which is very less and minuscule for a large, population like ours. Thank you very much. I'll be happy to take questions at the end of it, or I'll answer it in between in Q&A. Thank you.
Thank you so much, Dr. Somashekhar. That was a very wonderful presentation and gave us a good overview of what happens in Asia. The next topic is medical oncologist perspective and expectation from cancer surgeons. So we have Professor Florin Lodlik, who is Professor of Medicine at the University of Leipzig. He chairs the Department of Medicine at the Leipzig University Medical Center. He was Director of Education for the European Society of Medical Oncology between 2020 and 2022. Dr. Lodwig's scientific focus is on clinical and translational research in immuno-oncology and targeted treatment of cancer, with a special focus on gastrointestinal tract tumors. So over to you.
Thank you very much, Dr. Elanco and Dr. Piso, for the kind invitation. I'm very excited to be here as a medical oncologist, seeing so many attendees for this webinar from basically all regions of the world. And let me quickly share my point of view. It might be quite subjective, and I think this was also the intention, to ask someone who has worked for many years in a multidisciplinary oncology field to give a perspective, also a subjective perspective, what we expect from you during the training and when you are fully trained surgical oncologists. I show you here my declaration of interest. I'm working a lot with journals, also with industry. That's, I would say, quite normal when you're developing concepts in oncology. And there is something above that which I would like to tell you. My personal career was very much in a multidisciplinary field. I show you here the picture of Professor Jörg Rüdiger-Sievert, who unfortunately passed away a bit more than 1 year ago, who was an important person in surgical oncology, as many of you may know, and someone who boosted my career for many years. So working together, medical oncologists and surgical oncologists, is something which has become reality, fortunately. Sievert focused very much on a disease that nowadays we call adenocarcinoma of the esophagus and of the esophagogastric junction, a disease that has become quite common in countries with a Western or Westernized lifestyle, one of the reasons why we worked so much on it. And I will pretty much stay in this field to show you some of the principles which I find important from my perspective. This is also something that some of you may be aware, that when we are going to the esophagus and stomach and to the esophagogastric junction, there is a way how to classify the tumors at this junction, and this classification was created by Sievert. But it's not only about the anatomic classification for which this group worked. It's meanwhile also clear that diseases are distinct by their biology. And that's something which is also influencing the field of surgical oncology. When you see this anatomic unit reaching from the upper mediastinum into the abdomen, we are seeing different histologies, which of course need to be taken into account next to the different locations. And we see different biologies behind. And here from this Cancer Genome Atlas picture, you can see some of the important ones, like, for instance, microsatellite instability cancers. And what I want to tell you here is that I think that a surgical oncologist who is trained today needs to be aware of these things. And there are concepts not only which influence different medical treatments, we are also seeing increasing differences in terms of the surgical management of these diseases. Think alone about this subgroup of the microsatellite instability cancers, where completely new concepts are emerging, not only in the upper GI tract, also in the rectum and in other locations, even in gynecological tumors. So that's a first point that I really would like to stress, that during the training of the biology, of the pathogenesis of the tumors you are treating surgically should be in the background of your knowledge. That's another important picture from the time when I was trained in the hospital in Munich with Sievert, who was sitting there every morning with all of us in the multidisciplinary tumor board. I was kind of the surgical, the medical oncologist, being in discussion with all the surgeons. And we came together every morning. And what I learned during that time is that oncology of today is immensely multidisciplinary. And we really need to be able to take the perspective of the other disciplines, of surgery, of radiation oncology. And also we need to be able, if we want to defend our methodology, if we want to suggest the best possible treatment of a single patient, we should base our arguments on scientific evidence, not only on experience, which of course should not be lacking, but it's the scientific evidence which at the end of the day counts, next to experience and the patient wish to come to the best possible decisions. And of course, it's not only about the evidence that was created elsewhere, it's also the evidence that you create from your own experience, from your own databases, from your own research, which usually is the best one you can get because it applies to your patients in your region, the ones that you are seeing on a daily basis. I just give you short examples. Here, for instance, in these early days, that's an old publication if you want, so it's old knowledge from these days when I was still working with Sievert in Munich. We saw the arrival of new adjuvant treatment strategies also for the upper GI tract. And it was clear from the beginning that many patients are benefiting from that, but not all of them. There is a lot of heterogeneity in terms of response. So we tried to figure out if the early assessment of response by metabolic imaging, introducing FDG PET, can discriminate patients who will be responders and non-responders. That was the principle of this research. And we found that FDG PET is a quite sensible method. And we started to publish on that. I'm showing you here one of the major publications of that time that I was happy to lead. And I show you here again this aspect of multidisciplinarity. From the not too big group of co-authors, we see all the disciplines that were involved: surgery, surgical oncology, medical oncology, nuclear medicine, pathology, statistics, trial management. I think that's really an important task that we all have, that you have, to connect with the other disciplines, to exchange the knowledge and to do treatment and research together. These efforts ended in something that was meant to be quite innovative. We developed an algorithm where this metabolic response assessment decided if neoadjuvant treatment makes sense or if we should stop it and go immediately to resection. And that was also quite influential and went to inspire other groups in the world, in Australia and the US and other European countries, such as Czech Republic and United Kingdom. Another thing that was emerging was the question, what is better for our patients? And this is an example from esophageal cancer, but the same is of course true when we are coming to rectal cancer, to pancreatic cancer. Should we rather treat these patients perioperatively with chemotherapy or preoperatively with chemoradiotherapy? And interestingly, this study that we recently published in the New England Journal of Medicine was led by a surgeon, by Jens Höppner, and the majority of them, of the co-authors here, are surgeons, surgical oncologists from Germany, but together with medical oncologists and radiation oncologists. So you can see that surgical oncology really can make an impact on how we treat patients, even in the multidisciplinary field. Here's the straightforward design comparison of two neoadjuvant treatment regimens showing a clear benefit for perioperative chemotherapy compared to preoperative chemoradiotherapy for patients with esophageal adenocarcinoma, and with some important insights that we just shared at the last ESSO meeting. The real difference comes from the better control of distant relapses when we apply perioperative chemotherapy. While the incidence of local regional relapses was comparable between the two arms, a sign for me that meanwhile surgical oncology, with all the skills, has achieved quite a good control of local regional control of the disease, so that an additional local regional treatment methodology such as radiation is not needed in this patient cohort anymore. This would have been different probably when we go 25, 30 years back, when surgical oncology was not developed and not trained at that level. Also, the post-surgical morbidity mortality was quite reasonable, as you can see from these numbers. This goes into guidelines immediately. This is the update of our European guidelines. Here, the update of the American guidelines. So surgical oncology expertise and research really can make a big difference. Moving a step forward, it's another study that we published last autumn in the New England Journal of Medicine. It was the question again of preoperative chemoradiotherapy for resectable gastric cancer, gastric and EG junction cancer. And again, two arms were compared. The one that we consider to be a standard perioperative chemotherapy for resectable but locally advanced gastric cancer. And in the experimental arm, together with the perioperative chemotherapy, patients receive preoperative chemoradiotherapy. Interestingly, with no impact on survival at all. Another proof for me that an intensification of local treatment by the addition of radiotherapy is probably not needed as long as the surgical oncology methodology is optimal, so that local control is already guaranteed by the surgical procedures. Another example of wonderful cooperation here with my friend Magnus Nilsson from Sweden, and I'm coming back that we really need to defend what we are doing. Here I'm giving you the example of esophageal squamous cell cancer, where certainly in some settings, at least in some regions, the role of surgery itself, the esophagectomy, is questioned. And we should not be shy to put these questions onto a randomized controlled comparison. This is what I'm doing here in this global trial that is called the NEEDS trial, where in one arm, patients are receiving neoadjuvant chemoradiotherapy followed by planned surgery. And in the experimental arm, which is shown here, no surgery is planned. Patients are receiving definitive chemoradiotherapy followed by surveillance and by surgery only if needed, only if there is an incomplete clinical response or there is a local recurrence. So this is how we generate and should generate evidence together. I think you are all aware that we have entered the field of immunotherapy. Another challenge for us, medical oncologists, also for you, surgical oncologists. I would like to say that I find it very useful if you at least know the principles, how these drugs work, what side effects they can make, how they might influence the general health of our patients, how they might influence or maybe even not the safety of surgical procedures. I can promise you that these treatments will play an increasing role in the perioperative management of your patients. We have just, to stay in the field of upper GI malignancies, we have just seen a study on this year's ESSO meeting in parallel published in the New England Journal of Medicine that is giving proof that the addition of immunotherapy here with an inhibitor called durvalumab improves outcomes of surgically treated patients. We are also entering the era of personalized medicine. More and more genetic analysis, proteomic analysis are going into the field of the management, not only of metastatic disease, where everything started, but also in the treatment of localized disease. We have been talking a lot in the last years about HER2, one of the membrane-bound receptor tyrosine kinases that we can target with targeted drugs. And there is an important message which I would like to transfer to you. One of the challenges that we really have in the field of biologically targeted therapy is the heterogeneity of the disease, which means we meet a lot of tumor material because the primary can be different from the metastasis. Even the primary can be heterogeneous over the time. The biology of the disease can change. And it was mentioned by the first speakers that also, of course, how to take biopsies and how to assess the tumor is a necessity in surgical oncology today. We also have new drugs that we include into the surgical management as preoperative, postoperative treatments, such as the antibody drug conjugates. I see that the ESSO is doing a lot to train its members. We are doing the same in medical oncology, often together, always together, I would say, with surgeons. So cooperation is key. And here just a short summary, what I would expect: excellent surgical skills, of course, for the best of our patients, discussions based on scientific evidence, empathy for the patients, and collegiality, willingness to contribute to the generation of new evidence, understanding of tumor biology and the principle of non-surgical treatment modalities, and national and international networking. Thank you very much for your attention.
Thank you very much, Florian. That was exactly what we wanted to know. What are the expectations? We don't want to see us only as craftsmen or artisans of the scalpel. There is other skills we have to gain within the training. Now we move to our last presentation. Dr. Elanco was so kind and presented me, and I would like to present her now a bit more in detail. She is from London. She's internationally recognized for her education, leadership, healthcare, and policy, and she's a lot involved as opinion leader in surgical oncology, as you can see. And she had a pivotal role during the COVID response for which she was awarded with a Global Health Special Recognition Award just a few years ago. But she was also awarded the Medal of the Royal Society of Medicine for her work in inspiring and helping generations of colleagues within the Royal Society of Medicine. So you see, she's doing those efforts everywhere, as she's doing now with us with surgical oncology. And she was contributing a lot in education and healthcare, for which she was awarded 2019 a prestigious Global Health Medal. So we're very happy that Dr. Elanco is with us today, and she will complete this as good as possible, this image of surgical oncology worldwide, getting a bit more deep in the European situation. Afsana, welcome.
Thank you so much for such a kind invitation. So welcome. I have no conflict of interest, and I would like to say special thanks to my colleagues in ESSO who have shared slides through the ESSO, where true sharing of resources and knowledge truly exists. So moving on to our first slide. So the best chance of being cured of cancer is through surgery by expert surgeons with a deep knowledge of oncology. It's basically a summary of what Anna Wagstaff had said in her quote. So media talks about drugs predominantly, followed by lifestyle, particularly smoking and sunbathing, genetics, and food and drink, including dietary supplements such as vitamins. But we don't see much in the news about what the advances are in surgical oncology. In 2018, Dr. Albright, a journalist at the National Congress of Surgery in Munich in 2018, presented, and these were some of the conclusions that he came. There is a discrepancy between the important role of surgery for the patient's prognosis and its public's perception. Even progresses in the operative techniques and innovations and their positive impact are unknown. So in surgical oncology, quality assurance, certification, accreditations are hardly known and not attractive. However, immunotherapy is attractive and popular, as we've just heard from our colleague. So, what's the image or campaign for surgical oncology? On a European level, the European Parliament Special Committee on Beating Cancer report on strengthening Europe in the fight against cancer wanted to move towards a comprehensive and coordinated strategy. And ESSO proposed amendments which were included in the final Becker report and adopted by the European Parliament on the 16th of February in 2020. So ESSO constructed an open letter on behalf of the surgical oncology community, putting the spotlight on surgical oncology and building momentum for the greater recognition. It talked about the time for change, harnessing the full potential of surgical oncology for cancer patients in Europe. I would urge for cancer patients across the globe. There is awareness to the importance of surgical oncology as a core discipline in cancer care in Europe. Amplify the ESSO messaging on surgical oncology towards policymakers in light of the upcoming implementation of the European Beating Cancer Plan, which was launched on the 9th of November in 2021. I would say a lot of the work that ESSO has done can be used globally and should be looked at when we're looking at what we can do in our own centres across the globe. The ESSO statement on the implementation of the European Beating Cancer Plan conveying ESSO's key messages to policymakers and outlining how surgical oncology experts can contribute to realisation and success of the plan. Basically, it was released in March 2022. This infographic, which you can get from the ESSO office and the website, is sharing evidence and ESSO recommendations at a glance through an impact visual asset. Basically, it's picking up the important points like what is the value of surgical oncology as part of cancer care. Picking up themes such as surgical oncology is critical to ensure high quality cancer care. Surgical oncology has multiple roles in the cancer patient. Surgical oncology is cost effective and keeping pace with innovation. It also addresses things like unlocking the potential of surgical oncology in Europe. The ESSO's recommendations for these include recognising surgical oncology as a speciality, harmonising education across Europe. supporting research and innovation in surgical oncology and promoting the role of surgical oncology in the multidisciplinary team. It is now available in 10 different languages, as you can see, and if a language is not covered and you would like it in your language, I'm sure the ESSO board would be keen to hear from you, because as I said, a lot of these things can be used globally. So if we look at education and training at all levels, basically, education and training underpins all cancer services and thus informs onco policy. It needs to happen at all levels, from undergraduate to postgraduate and continuing medical education throughout the professional's full career. Good quality training involves healthcare professionals at all levels and allied specialities, as when we provide patient care, it should be holistic, placing the patient at the center of care and personalizing it specifically to them. Variations in cancer surgery outcomes may be linked to variable training and resources available across the globe. And to address part of this, ESSO has produced and published a core curriculum in surgical oncology. We heard from our colleagues earlier that regarding medical oncology, it links in with a lot of the surgical provision we give. So that united approach is really important for the patient. So if we look at factors that affect cancer surgery outcomes, these include economics and the financing of cancer surgery, also include systems to deliver cancer surgery, surgical research, engagement and investment, the political framing or policy activity, and of course, all of this is on the basis of cancer surgery workforce, which is again, ultimately based on training. And training and education underpins all of this. So the length of training, the quality of training, the skills of trainers and training the trainers is so important. Fellowships where we can learn from each other across the globe, and then obviously assessment and examinations, all these underpin good quality education for the surgeons, for the professionals, and the interprofessional learning, and this ultimately improves patient care. So when we look at years in training, and we look at variations in training of surgical oncologists, there's a survey conducted from 174 of the 211 countries worldwide, which is an 82% response rate. The years in training, pre-medical education, medical school, surgical residency and fellowship range from 8 to 17 years. And then if we look at the economics of training, there's an increasing economic standing, increasing development human development index, and basically you need longer training because we have more to learn. The place of training, so the lack of domestic surgical oncology fellowships can sometimes restrict our training and in our particular countries. And this is a great opportunity to actually travel and to see what our colleagues are doing in other countries. And so fellowships have become very important in the surgical oncologist's training pathway. Difficulty to integrate knowledge acquired abroad into native systems can sometimes be difficult due to the resource limitations. So if we have a look at variations in training in surgical oncology, basically surgical oncology is not recognized as a specialty in most EU countries, only 67%, but training is less varied than continents in terms of duration and intensity. Cancer surgery is done in all centers, not always by surgical oncologists, but by surgeons performing occasional cancer surgery. Standardization of curricula, accreditation and examination across Europe may help reduce health outcome variance, and in fact across the globe. So this is something that Charles Balch actually suggested. Who is a surgical oncologist? A surgeon committed to treating patients with neoplasms, with oncology experience and expertise about all facets of cancer, committed to precision surgery, multidisciplinary approach, holistic understanding of the patient, and then also being a leader and a researcher in their field. So if we look at this unique role of a surgeon in cancer care, they're often the first point of contact. Surgeons have a big impact on patients' decisions. Second thing is diagnosis. Surgeons have a critical role in diagnosis and evaluation of operability. Next role is in the MDT. The multidisciplinary approach to cancer care is critical for better patient outcomes. And then we've got primary cancer treatment. Most patients still need cancer surgery through their treatment journey. So the role of the cancer surgeons is important in the patient's journey throughout care. So good quality education and training is important for cancer surgeons' journey in order to provide good quality care for their patients. And that's continuing education throughout their working life. So cancer services provision should be based on investment in education and training throughout the career, creating a fit-for-purpose workforce through good education and resources that are available to provide good care for the patients, continual improvements throughout surgical research, continual onco-policy development, and this leads all together into good patient care. They all have to work in a continuum and harmony in order to provide lasting innovation and best care for patients. Just to note that there is a survey currently being conducted on mapping the surgical oncology in Europe among the ESSO national affiliated societies, and the findings will be presented in ESSO 44. So ESSO is still doing the work on this in the background. That's been a whistle-stop tour of basically surgical oncology and oncopolicy and education. So thank you for listening.
Thank you very much, Afsana. Thank you for keeping in time. We have now at least 25 minutes to discuss some things. We had a lot of interesting questions. Thank you very much for addressing them. And also thank you very much to the speakers that have already answered them, which is very kind. I tried to concentrate the questions in categories, and many of them do focus on this crucial question. Do we need organ specialists or do we specialists in surgical oncology? Because we saw surgical oncology means a lot of organs, from thyroid to anal cancer. And I was wondering, and I would like to ask all our speakers, Dr. Are had to go to a clinical case, unfortunately, but we still have enough expertise in this webinar. So I will ask all of you to answer this question. Do we need organ specialists or do we need specialists for surgical oncology, and how can they combine them? Maybe SP, Professor Somashekar, would you like to start with?
Yeah, sure, thank you. It varies from country to country. Now, if you look at the quality, patient perspective, to reach the best research and quality, organ-specific surgical onco in long run would be the best for a country if we can achieve it. But then we need to see if 95% of cancers in a large population country, say like India or Asia or African country, are done by non-surgical oncologists, where the ratio is so low. If we try to practice like breast surgical onco, thoracic, GI, probably no patient, less than 1% patient would get them. So for large countries with not well-established surgical onco program, it's nice to start like India with an intention clearly in a decade to move to a organ specific. Everybody will not be able to reach that. No use having organ specific reaching 1%, or at least you have a qualified surgical onco who knows medical surgical background, the protocols and what it takes in onco. At least it does a good justice in between. So India is in exact cusp of this. Last 3 decades, we were general surgical onco. Now last 5 to 7 years, we are moving almost completely to organ specific, which would be the right for any country in long run.
Okay, thank you. That's a clear statement. Dr. Elanco, Afsana, what is your opinion on this?
So I think you do need to know your organ specifically, and then the specialist surgery of surgical oncology within that. There's countries that have also taken the route of being specialists in the organ specific and then doing specialization to actually look at surgical oncology to address the specific areas for the patients, because obviously you need to know the biology and the detail behind it, which Florin very eloquently described. And we need to work with our colleagues in order to provide actually a coordinated care. So there's probably always will be an overlap because no one country is the same. And in order to get quality of education up to a certain level, and also we have to remember innovation. As we get new technologies involved, we then have a new learning curve to actually address that as well, to give the best care to our patients.
Yeah, thank you very much, Afsana. And what about you, Professor Lodig, as a medical oncologist? Do you expect somebody in the MDT which is specialized on organs, or do you need somebody that has a broad spectrum as a surgical oncologist?
Well, in the bigger centers, it's also a question of volume, and I mean, our MDTs, and it must be the same for many who are here, are already quite full, and it's almost impossible to cover a very broad range of diseases. I would say for training, it's a big advantage if some general principles are trained, if you also can learn from the other diseases. So during a training period, it's good to be broad. To get a lot of experience and a broader field of knowledge. For the sake of quality, I believe that then in a later phase of training, a focus on a specific organ is beneficial. Less complications, higher quality of surgery, probably, and at least I can say that from my perspective as a medical oncology, per organ, there is so much more complexity now that it will be impossible already today and even more in the near future to know all the details about the different biologies and the different aspects of treatment in all the fields.
That's right, Florin, isn't it? Because in some ways we need to know the organ-specific diseases very well and the surgery of that well, and then look at the specialist surgical oncology that we need to look at and focus on, and the added training around that.
Yeah, if I may add to the situation in Germany, I was very pleased to see that there is a limited number of specialists that are allowed into the fellowships. Now, that's not the case in Germany. We produce probably the highest number of specialists in surgery in Europe because there is no exam for the admission. And in my opinion, the clue is we need, after training in general surgery, we need as Florian Lodig said, to complete a fellowship in surgical oncology and then on top the specialization in organs. That will be the ideal situation. The variability in Europe is extreme. So just a few countries have a specialist in surgical oncology and a training.
That's one of the things, Pomplio, that is worth considering here, is that in your own country there might not be necessarily a fellowship that fits what you need to do, but to travel and to find out fellowships overseas. And I guess for a lot of the trainees that are connected on, or people who want to go into surgical oncology as a specialty, how would they find these fellowships?
Well, they still train in Germany because we have a sort of specialization in gastrointestinal surgery on top. So this has not as a bright spectrum as it has the general surgeon. So there is a sort of specialization. And then we have a structure here with a lot of certified centers by the German Cancer Society. So within the center, you get specialized by participating to all the activities, knowing the studies and so on. But there is no specific track. We try to organize one, finishing with a fellow of the European Board of Surgery offered by the OMS together with ESSO. But that's not the ideal situation. What we want to is to generate a call in Europe within the European Cancer Plan. We talked about that a few times to generate a call with financial support within one of the frame programs in Europe, and to create a fellowship that can be established in each country, because the situation is different in every country. And you have to respect that, otherwise you will not be able to implement it. So there are just a few German surgeons that did benefit from international fellowships, like the one mentioned by Dr. Are at the Memorial Sloan Kettering Cancer Center. But there is no structure in it. And Another question related to that in the webinar was, should general surgeons allowed to operate on cancer patients at all? Now, Afsana, you can moderate this question.
Yeah, I think the thing is part of it is that it's if you don't have cancer surgery as a speciality, you have to treat the patient. And Somashaka, Dr. Somashaka, you can comment on this a bit further, can't you? Because in India, you've seen this transition recently.
Absolutely. I'll just give an example. The most common cancer in India now is breast cancer overtaking cervical. 99% of them are treated in medical colleges, and the majority of medical colleges don't have a cancer center or a surgical oncologist. If we insist that you need to be treated by surgical onco, probably 90% of breast cancer will never go under knife. Even though we would love to have a surgical oncologist go there. Remember, last 3 decades, there were only 8 seats in India, 1.4 billion, 8 surgical oncologists per country. Now today we have 200. Still it is nothing. So however, we would allow them to have an access to surgical onco. Better would be to elevate general surgeons who have no access to surgical onco to a level to do a minimum acceptable. I would say a minimum acceptable treatment for that cancer until we work parallelly over next decade to try to put a surgical oncologist there. A big country like ours is difficult. So we believe through society, general surgeons' knowledge of onco through various dedicated courses, short-term training programs, bring it up. At least they know what is minimum to be done, and they can ask for help when it is required.
That's very important, isn't it? There's this time period for training to occur, and you'll always have a lag when you're trying to change anything or innovate anything. Pompilia, would you like to address that question as well, please?
Yeah, I think it's indeed related to the options you have in your own country to get specialists in surgical oncology. And if in countries like mine, where you don't have this, where this specialty doesn't exist at all, you know, as I mentioned, our national cancer societies try to concentrate these patients in center where there is a certain expertise, mainly driven by interprofessional and interdisciplinary work, but also by the volume. Volume is a central theme in Germany right now. So there are a lot of regulations which focus on the number, you know, for pancreatic cancer, for esophageal cancer, for everything. And this is influencing the training as well, because you can only create specialists in a hospital where you have all the organs which you can address. So if you could try to train somebody in surgical oncology, but you're allowed only to perform esophageal cancer and gastric cancer, but no pancreatic or hepatic surgery, then you will not be able to offer somebody a complete training in surgical oncology. So that's again a big difference from country to country within Europe, and then between the continents. So in this situation, we will have a lot of, in these countries like ours, a lot of general surgeons or surgeons, they may have a gastrointestinal specialization that are operating upon cancer patients.
I think that's a very important point, because there's lots of colleagues that have trained as general surgeons and have conducted various operations on cancer surgery throughout their lifetimes, and are actually very experienced, especially where you've got big centers, and you've got centers where you have large volume, as we see in quite a lot of the developing countries. And low middle income countries, you see large volumes coming through, and so they will have a level of expertise. And I don't think we can underestimate the general surgeon's value in this. But I think it's working towards the expertise of cancer surgery and trying to bring those extra added sort of biology behind the cancer. And this is where I'm going to bring in yourself, Florin. From your experience and working with the cancer surgeons, what's your take on it? Obviously coming from a different angle to us.
Yeah, absolutely. I mean, I cannot really comment on the surgical expertise, and I'm sure that experienced general surgeons who have done a good training and a good lifelong experience, that they are able to treat cancer patients. And we should also be aware that there are many regions in the world, especially in the low middle income region, where there is a real lack of surgeons in general, and patients can be happy if they find a surgeon who in principle is trained to treat them. But I also must say that my perspective as a medical oncologist, if something goes wrong in cancer treatment, it goes wrong from the beginning or at the beginning. And it's something we cannot repair in due course. If some principles of cancer surgery are not respected at the time point of the diagnosis, of the treatment planning, let me tell it in simple words, it's over. The cancer is not treated appropriately. And so we really should focus that those who have the first hit in their hands, that they know what they have to do together with their friends from medical oncology, radiation, etc. I think I cannot mention that enough. We are not able to repair things that have gone wrong at the initial hit.
Yeah, I agree with you, and it's very much in the presentation where I said it's that continuum, and as a surgeon, you need to work with all the different specialities together in order to focus purely on the patient, and making it personalized. Back to you, Pompilio.
Yeah, well, we don't want to minimize the quality of general surgeons, really not. So they're really good surgeons, skilled surgeons. As I mentioned, they're artisans of the scalpel. But cancer surgery includes some knowledge about carcinogenesis, about epidemiology, includes the knowledge about the ongoing and performed studies. You've seen in a presentation from Professor Lorik, insights in immunotherapy, and the main clue is this interdisciplinary setting where you have to discuss, to negotiate. You have the guidelines give you some frame, but then you have to negotiate with the specialist and then with the patient as well. And that's something you have to learn. That is something that has to have a tradition in an institution where you work. That you need a culture in your country on that. And somebody addressed an interesting question now in the webinar in the chat. If you have only organ specialists, what are you going to do if you have to perform a multivisceral resection? So do you get 3 or 4 organ specialists? Very, very difficult timing. And who is keeping the overview? Yeah, that's an interesting question. SP, what's your opinion on that?
I would agree. So we will look at it in modern surgical oncology. Where do we end up with multivisceral resection? One is the sarcomas, the abdominal sarcoma. Now we know sarcoma itself is a very big, large surgical onco training program. Second is a PSM program, peritoneal surface and pseudomyxomas, PMP. These are the 2 programs where you end up doing large amount. But now once you finish your surgical oncology, these 2 are already advanced fellowship. Like in my university training program, we have a surgical onco training program, 3 seats a year. So I have 9 fellows who come through Ministry of Health for surgical onco training. Post that, they have 1-year fellowship in PSM program. So multivisceral resection. I agree. Where does it end? Then you have a quadrant-wise surgeon, but a multivisceral surgeon needs to have everything. But I believe sarcomas and PSM and pelvic exentration. So these 3 actually are an extension of an advanced training already. So it's there.
Yeah, we see in some of the specialist surgical oncology centers where, say, you're doing colorectal and you're going into the pelvis, so you'll have the gynecologist there with you to help you with the pelvic clearance as well. So we do see this core sort of 2 specialties working together, and I think it goes back to what Florian in one of my slides showed, that you need to work with the different specialities for what's best for the patient, because there are various different immunotherapies that are coming along, and maybe surgery isn't the first line anymore, and maybe it's a second line, or what do we do? And I think those discussions for specific patients are important, because obviously with an aging population, we'll see more comorbidities in our patients that have lots of other diseases, and we need to look at how that works together. And also with minimal invasive surgery, hopefully the outcomes for the patients are better. And in that way, with the technology improvements, maybe we can do surgery that's more complex from a minimal invasive point of view.
Now, there is another interesting question regarding on the knowledge about the importance of surgical oncology within the country and the population. We had that study in Germany looking for the press for the print media, how frequently surgery and oncology was addressed, and it was like in a biggest population country in Europe, it was like 2 or 3 times in a whole year. So if you compare that to immunological treatments from medical oncology, they had a small survival advantage of 2 months, and there is already a lot of reports on breakthrough in the cancer treatment. Now, why is it that? And Professor Lodi can think about it, and maybe you, Afsana, what's your opinion on that?
I think the thing is, as we see more and more immunotherapies developing, we will see more and more response to the cancers. So obviously, Florian will be able to say more about this. But you've got bloodborne cancers, where you are seeing more of these immunotherapies actually being effective, and I think things like malignant melanoma as well, where you've seen these immunotherapies actually making patient care hugely different. And I think the more we see of the immunotherapies, they are very costly to actually develop, but where they do work, they have had some good results. That's right, isn't it, Florian?
This is absolutely true, and I would not underestimate the advances we made in some of the diseases or in subgroups of diseases where novel targeted or immunotherapies really made a big difference. I think it's always in the public, things that are completely new are very fascinated. It can be about new drugs, cellular therapies, vaccines, also new machines. But as a real friend of surgical oncology, I must say there is so much interesting things also going on in surgery that maybe the surgical societies should not be shy to show that what is possible today. And it really deserves it. And in the end of the day, of course, we need to work together in all that, also in the awareness. It's not about one methodology more visible than the other one. It's the joint effort we are doing, the multidisciplinary effort that in the end of the day makes the difference for the patient. I just want to mention that I'm a bit sad to read, and I think that's also a reality, that still many patients do not get access to all these things. I know it for sure for medical oncology. So many patients worldwide simply cannot afford these horribly expensive drugs. But there is also comments that some patients, for money reasons, for economical reasons, unfortunately, do not have access to expert surgery. It really makes me sad, but it's a reality.
I agree with you, Florian. This is one of the reasons to have these discussions, because
Yeah.
it's heart-wrenching for my colleagues that sit in these countries. They know what the gold standards are. They know what is available for patients and what can be achieved, and yet their hands are tied by economic resources. They know patients are not getting the best care, and it's about providing an equal service no matter where you're sat. And I think that's why webinars like this, discussions like this, are so vital to actually say these are important, and why shouldn't patients in different locations get the same care? And it's often resources, unfortunately, and resources that are focused elsewhere rather than on healthcare. And it is really, I can tell you from the bottom of my heart, from my colleagues that sit in these countries, it's really heart-wrenching for them. And I take my hat off to them of how they provide care with minimal resources. And I mean, we talk about robotic surgery, we talk about minimal invasive surgery, and talk about all these technologies, but they're extremely expensive for these countries to actually have them. And now with the increasing platforms of different robots, hopefully it will open up the door for other people to be involved. And maybe it's a question, a bigger question for society. Should we be providing some lower cost solutions for low middle income countries to actually provide equal healthcare for their patients? I'll hand over to you, Shamashar, because I'm sure you've got some comments on this.
No, I fully agree with you. In India, we have a very important phrase, Indian solution for Indian problems, made in India, make in India for Indians. So we know what is best. What are the use of knowing the best, which majority of population may not be able to afford? So this is where I believe the surgical oncology societies have a major role to play. Like in India, we have a Indian Association of Surgical Onco, which is a counterpart of SSO and ESSO. We have a good collaboration, and the ABSI, Association of Breast Surgeons of India. Every year we bring a guideline. What is the minimum accepted standard of care which can take the bar, to 80 to 90% cure in a energy resource country like ours? And we also know now NCCN has acknowledged, that NCCN for many cancers now have a standard guideline, which is evidence-based. Also, they have a energy, financially challenged country guideline too. So where, yes, there is the best, but the best to the second best would make only 5% difference. But if you follow the second best, which is the minimum, which may be affordable, 95% of justice you are done. So in India, I'm in major societies in India, and we publish our own guidelines, practice consensus statement for India, for Indian problem, for Indian solution, where we write what is the best, or what is the second best, where 95% you are done right. I think this is where the societies bridge the gap.
Thank you very much. I think we will have to wrap up. We had a wonderful 1.5 hours, very interesting. I think we all agree that beyond the surgical skills, surgical oncologists need to know more about the diagnosis and treatment of cancer, and how to cooperate not only with other disciplines, but also with nurses, site oncologists, and so on, and how to deal with the patients, because conversation with patients is a very difficult issue as well. And also be up to date regarding studies. I think we have to talk about this more in our communities, not only hide in the operating room. I know we operate a lot, all of us, but the committees and the guideline committees and all the others, they talk during the time we operate. So we have to be there. That's important. And I think at the end, we all agree we need more fellowship programs, more options for specializations in surgical oncology. And ESSO will stick on this, and I'm sure in all the other countries as well. And I thank you very much, Professor Somashekar, Professor Lodik, Professor Are is already in the operating room. And Dr. Olanko and myself are very grateful that you took your time to join us. We thank also the ESSO office for supporting this meeting. You will have the possibility to see the recordings on the channel and address questions in the coming months. Thank you very much.
Thank you so much.
Thank you.
Thank you,
Thank
everyone.
you and
Bye.
goodbye.